Hello, everybody, dear friends, dear colleagues. Welcome to BMed. I'm Dr. Alexander Dorman from Geneva, and today I have the pleasure to welcome a very special episode of BMed Learn from the Master in Shoulder series. And I have the pleasure to welcome one of my previous fellow, Dr. Joe Xu, and a lot of other guest speakers that will be introduced by Joe. Joe became a friend after 1 year. I don't know if he learned something in Geneva. I just know that he became completely cheeseholic. Joe is completely hyperactive, doing a lot of science, doing a lot of research. And actually today they will present unbelievable cases, and I really enjoy to discuss them with all you guys. Joe, this is your turn. For the community, don't forget to submit your questions, and we will try to address as many of them as possible during the Q&A session that will follow. Joe, your turn.
Yeah, thank you, Alex. And I have to say, when I was in Geneva, the term fellowship is like a term slave. Okay, so I was with Alex from 2018 to 2019, and I think it's the most memorial part of my life. Okay, and this is Alex. He's a workaholic, even in holidays. Okay, so he has very avant-garde ideas, and he published it and try to influence others all over the world. Okay, so I have to say I'm sorry that I didn't learn 100% about you, but I learned the easy way to put our patient before the surgery. Okay, and the 10 commandments. Uh, and Alex's idea has influenced the Taiwan shoulder a lot. Okay, because every time when I have a presentation, I always remember what Alex has said about the tendon transfer or about the reverse reduction. Okay, so today we are very honored to to be invited by Alex, and we have three very prestigious guests. That Professor Peishi Zhou is from Kaohsiung Medical University, and he took care of many of our national athletics. Okay, so the Professor Xiaoli Ma is from Veteran General Hospital in Taipei, and he's the pioneer of arthroscopy in Taiwan. And the third master is Professor Guo Yaoxu. He's in Changde Memorial Hospital, which I work with him. He's my mentor, and he has very experienced in very difficult shoulder cases. So today we are very honored to have the three masters with us, and of course Alex, because I'm his fellow. So I'm sorry to say we cohort, but I think Alex will give us very good ideas about the European view of the shoulder and the Taiwanese view. I think we will have a very good discussion today. Okay, so I think we should start from Professor Ma, and then we'll have to like a 10-minute discussion with Professor Ma's topic, and yeah, Professor Ma, please.
Okay. Can you see my slide? Can you hear me?
Yeah, perfectly.
Okay. Hello everyone. It's so nice to see you online. It's my great honor to be invited to the BMAT, and this is a very good the opportunity for us to reunite it online. So today I'm going to share with you my clinical experience about how to make a better repair in large to massive rotator cuff tear. So before the surgery, we need to know the tear that can be repaired or not, especially in the large to massive tear. So there are so many ways to predict the repairability of the tear. But during the surgery, if the footprint was exposed after the repair and incomplete covered by the tendon, for me, this is a repairable tear. But if the humeral head was exposed and uncovered by the tendon, and this is we call it a partial repair, and this is irreparable. So in this presentation, all the tears were repairable, but most of them, the footprint were exposed. That means the footprint was incomplete, covered by the repair tendon. So in my own series of a large to massive tear, there's only 24% of the tears can be repaired directly to the bone. That also means the supraspinatus always, the atrophy or fatty infiltration is very difficult to repair back to the GT. And the rest of the tears is repaired. The rest tear will repair in the marginal convergence with either tendon to tendon repair first or tendon to bone repair first. So what's the difference between these two techniques? The original margin convergence repair is a side-to-side repair first, and then followed by the edge stabilization of the tendon to the bone. But I think this technique is only to close the defect rather than restore the anatomy. So while if we repair the tendon to the bone first, and then can repair the infraspinatus to the GT near its original footprint as much as possible, then followed by anterior cup to bone, and then finally edge stabilization of the rest of the tendon. I think these techniques can restore the force couple, and then for a better the functional outcome and a structural outcome. So I also found that the repair rate is very high for the direct repair with a single row. So why I use a single row in this, I will explain this later. And also the tendon to tendon healing is not so promised in the tendon to tendon repair, because probably the tissue is not good or tension is very high. So I change the repair sequence, and that is repair the infraspinatus to the GT first, and the rest of the cup to the GT later, and then final side-to-side tendon repair if there's enough tendon. And even later, I changed the sequence of the repair. That is, repair the medial edge to the GT with the suture anchor, because I think that may hold a great power and the better power of the soft tissue. So we did a preliminary study in a repair of 76 large to massive tears, and to check the repair rate after different repair techniques. And we found that the repair rate was higher, around 40% in the direct repair, and also in the tendon to tendon first margin convergence repair. But but in the tendon to bone first marginal convergence repair, the repair rate is lower than 30%. Although there's no significant change, but there's a trend of the improving the postoperative structure in the tendon to bone first marginal convergence. So the repair sequence for the large to massive tear, of course, we had to repair the subscapularis to the LT first, and then repair the infraspinatus to top of the GT as much as possible, and then the rest of the anterior cup or the tendon to bone. Finally, repair supraspinatus to the medial edge of the GT with suture anchors. So just like I mentioned, most of the large to massive tear, the footprint was not able to be completely covered by the tendon with any kind of a repair technique. So it is not easy to do a double row repair. So that's why I always use the single row repair. But just like we saw, the single row repair, the repair rate is high, around the 40%. So I think probably we have the better way to increase the healing rate after this kind of repair. So I designed a so-called suture spanning augmentation. So which is we put two sets of matrix suture across the single row repair, one in the infrasymnatus and the other one in the suprasymnatus. I hope this kind of augmentation can increase the force and decrease the tension over the original single row. So it looks like it's very easy. Just put a wire, one anchors, and two sets of matrix sutures. So this kind of augmentation, the result is good, and we found also the bare area. I mean, the incomplete cover, the GT can also have a very good granulation tissue as well as the healing of the repair tendon. So we did a prospective the randomized study to compare with this augmentation the repair to the single row repair. So this is we can see there's a significant improving the structural outcomes. The repair rate is lower than 20% compared to the single row repair, which the repair rate is over the 40%. So I think this is a very good and very simple the technique to improve the outcome of the large to the massive tear. So all we know that recently the long head biceps transposition is very popular. But the long head bicep has been used in incorporate the rotator cuff repair and augmentate in the rotator cuff repair for many years. But recently, the transposition is another the kind of a technique. Someone used this as a part of the superior capsule reconstruction, and the technique is not very difficult and have a good result. So recently I used the transposed the long head bicep tendon. If the bicep tendon is intact, is good. So incorporate into the I just mentioned the tendon to pole margin convergence repair, and the early result is look promising. So probably in the future I can show you more of this kind of augmentation in the large to massive tear. So finally, I will make a short the conclusion. For my own experience, I recommend repair large to massive rotator cuff tear. The very important is a repair sequence. The subscapularis first, infrasymnatus to top of the GT, the latter, and then the others, the tendon to bone. Finally, the suprasymnatus to the medial edge with suture anchors. If the footprint is not completely covered by the tendon, probably we can use the suture spanning augmentation that will get a very good healing. But in the future, I think if the long head bicep tendon is intact, then we can do the long head bicep transportation augmentation in this kind of tear. So from the mechanical point of view, I think that this is what I think we can do better to have the better repair for the large to the massive rotator cuff tear. So thank you. That's my presentation.
Thank you, Professor Ma. And yeah, so Alex,
yes, Professor Ma, congratulations. It was clear and you had very nice illustrations. So thank you for this. My first question is, so now you completely stop to do side to side repair. Is it correct?
Sorry, you mean?
Professor Ma, do you stop to do side-to-side repair?
Oh yeah, yes. I stopped to do the side-to-side tendon repair, but I do the tendon to bone repair first, and then if there's enough tissue, I will do the final side-to-side.
Okay.
If there's enough tissue, but if the tissue is not so good, I just suture the tissue to the medial edge of the bone. So.
Okay. So for you, partial repair is still something that is useful in your practice?
Yes.
Yes. Okay,
Yeah, I think.
agree.
I think the first couple is the first couple. We restore the first couple is more important than we cover the defect.
Okay. If you don't have a completely covered footprint, do you try to create a medialization of the footprint by something like 5 millimeters with a burr? Is it something that you do?
Yes, I did. But even I did the medialization, I still found the direct repair had a very high repair rate, around 40%. So probably the tension, probably is the supraspinatus is not good. So I just quit to focus on the supraspinatus. I just focus on the infraspinatus and the anterior cuff. So I just leave the supraspinatus if this is not able to repair back to the bone. I just focus on the infra and the anterior cuff, suture back to the bone.
I read many years ago, and I think it was coming from Japan, but I have a doubt. It was a presentation a study showing that even if at the end of the repair with an MRI, there is not a full coverage of the footprint, if you repeat MRI, you will see that the tendon actually migrates laterally and at the end cover more footprint. Do you have any experience? Have you done repetitive sequential MRI to your patients?
Okay, I think that is not the tendon tissue. I think that is a granulation tissue, just like Dr. What we call Dr. Snyder. Dr. Snyder published such kind of experience. He used the microfractures, and then he repaired the tendon in the medial edge of the footprint, and then the footprint later will cover by all the tendon-like tissue. But I remember there's the paper say they did a biopsy. This is not the tendon tissue. That's the granulation tissue.
Okay. And so you mentioned at the end that you are doing from time to time long head of the biceps augmentation, and this is a technique that I love, and I think that Joe is using it as well. What is your attitude with this large tear or massive tear? Do you systematically use the biceps, or do you use the biceps only if you have a partial or a partial repair?
Yes, but usually in the large to massive tear, the bicep long head is not so good. So probably we have to check the long head bicep. If the bicep is intact, I mean less than about 40 or 30% of tear, probably I can use that to transposition. But if the tendon is mobile and can cover the footprint, and then I don't do that. I don't do the bicep long head transposition. Only in the incomplete footprint coverage and the bicep intact, then I will do the long head bicep transposition.
And you, Joe, is it systematic now in your practice?
Not every case. Just like I mentioned, the bicep intact and the footprint is not complete cover.
And you, Dr. Xu?
Oh yeah, actually it's a very good technique, and I learned from Dr. Yang Bars, and he published the result that the biceps SCR, he calls it a biceps SCR, increases the healing of the infraspinatus. So now, if it's like I just do the same as Professor Ma, if the cuff is mobile and can cover the footprint, I just do the bicep tenodesis, just like Alex do, just do tenodesis with a medial row anchor and cut it intra-articularly. And I think and I leave a little stump in the most anterior part as a anterior cable. We call it, I think it is like an anterior cable augmentation. Just leave a little bit thickness there, and then we do the easy double row like you and Philip Cullen developed. Now I'm back for 3 years and I got like a 300 or 400 cuff like doing like this. But if it's a large tear, it's not repairable. I'll do the transposition, reroute the biceps posteriorly, and cut it distally. So I have a question for Professor Ma that if the biceps is okay, so and where did you put your biceps if you wanted to reroute your biceps posteriorly? Is there any exact millimeter, like 5 millimeter posterior to the bicipital groove, or you decided by how much your infraspinatus can pull anteriorly? Yeah, that's my
Yeah.
question.
Okay. So the first thing is I always put the bicep in the top of the GT. That just like a part of the superior capsule, the reconstruction. Because if you put too much, probably tension is too high. But I always release the transverse ligament and put all the bicep out, and then put the bicep on the top of the GT, and then the infraspinatus just the suture back to the GT as much as possible. Even though there's a gap between the infraspinatus and the long head bicep, I don't struggle to repair the bicep tendon to the infraspinatus. I think bicep tendon only had just you mentioned probably the part of the superior capsule the function. Okay. So for how far? Probably just couple of centimeter, not too much.
Mm-hmm. And we can see the comment. There's should be a Dr. Eddie Lowe, and he asks about the opinion of the spanning augmentation, because I think it's a very fantastic technique. As he asks, is this technique? Do you use this technique every time? And my thought is that this spanning suture can be think of provide a spacer effect like a balloon, or like a balloon made by sutures. Is that possible, or
okay?
Yeah.
Yeah. Okay. So for me, in my point of view, I think restore the false couple is more important to a spacer effect. Okay. Mm-hmm. Superior capsule reconstruction for me, I think that's only that's only a spacer effect. It didn't change anything. The muscle still atrophy and still retract. It just covered defect. But I think the most important technique is to do the partial repair in such kind of. So I don't do superior capsule reconstruction anymore. I just do the partial repair to restore the false couple. If in a young active the patient, he need to the muscle power, then I will add the muscle transfer. So that's what I do. So I just do the partial repair to restore the false couple. And the suture spanning, okay, the suture spanning I just used in the incomplete foot coverage, in direct repair or in the margin convergence repair. If the footprint is not the foot is not covered very well by the tendon, then I will do the suture spanning. If the footprint can cover completely, that means the repair tension is lower and there's a very mobile, then I don't do the suture spanning the augmentation.
Cool, thank you. And I think there's another from audience is Wei Ren Chen, which we know about him very well. He's a very good, talented surgeon as well. And he asks about because of time, I think it's the next question about the Professor Ma's talk. He asks about, do we routinely perform the articular side release for retractive massive tear? As far as when I was in Geneva with Dr. Lederman, actually, I seldom see him do a very extensive release. Maybe, Alex, you can give us some your thought.
Effectively, if I trained with Steve Burkhardt, and Steve at that time was repairing all the cuff at all cost, and so I adopted the same attitude, meaning I really try to repair as much as possible. So if the tendon is not coming back easily to the footprint, I will do a release, and this is rather an anterior and intra-articular release. I stop completely to perform posterior interval slide, but I'm still doing, depending on the type of the lesion, some anterior interval slide and intra-articular release. Honestly, we don't have science behind to say if it really allows to have more footprint coverage, but this is an habit that I had and that I developed with Steve.
Mm-hmm. Cool. Yeah, Alex have developed many themes in shoulder territory. Huh? Okay, I think because of time, and maybe you can shift to next case. Professor Zhou will talk about a very unique injury in Taiwan. That's the overhead thrower, because Taiwan are now ranked the second best baseball country now in the world. And most of the athletics are being treated at Dr. Zhou's clinic. Yeah, and maybe Dr. Zhou, please give us your good experience about this athlete. Thank you.
Thank you. Okay. Can you all see the slides now?
Yes. Very well.
Good. Okay. Thank you, Dr. Lederman, for inviting us. I'm from Kaohsiung Medical University. I'm Paul Chow, and this is a little map about Taiwan. And Kaohsiung is actually the southern part of Taiwan. It's a seaport city with a lot of seafood and hospitality. And so, as we know that among baseball players, shoulder and elbow has the highest injury rate. And that's probably because of the during the late cocking and early acceleration phase, there are tremendous stresses on the shoulder and on the elbow. So that can cause internal impingement of the shoulder and also even slap lesion, which are one of the commonest shoulder injury among baseball players. So as to the mechanism, usually is related to repetitive overuse on the overhead motion. And some can occur due to compression injuries, such as fall on an outstretched arm. Of course, you can use some physical examination to make some differential diagnosis, but MR arthrography is actually probably the best tool to diagnose slap lesions. As we can see, this is a type 2 slap lesion on the coronal view. And one of the options, once you have the slap lesion, is surgical treatment necessary. So this is a new article just published this year on Journal Shoulder and Elbow Surgery. And there are 5 articles included in this review article. And out of 244 total athletes, 162 are elite athletes. And the return rate, the return to play rate is 53% for the total athletes and 52% for elite athletes. But for return to pre-injury level is only 42%. There are some risk factors or poor related to poor outcome after non-surgical treatment. One is older age, and another one is baseball pitchers. Traumatic injuries or positive compression rotation tests or associated rotator cuff tear are also poor result factors. So let's have some examples. This is a 24-year-old outfielder. He was diagnosed with slab lesion plus partial thickness tear of the supraspinatus on 2009. He actually did well after physiotherapy and returned to play 1 year after the injury, and actually played 7 years on the professional Chinese baseball league until he had another accident 7 years later. And then we can see on the MRI, the cuff tear become more severe. So he actually needed surgery to repair the cuff and also the slab lesion. And he returned to play again a year after, and he still continued playing on the professional level. How about the result and outcome after the type 2 slab repair? This is a study, at least 2 years follow-up by Louis Yocum, and we can see for these overhead athletes, only about 57% can return to pre-injury level. What are other options for the surgical repairs? Slab repair is one of them, and bicep tenodesis is also one of them. So this review article compared out of 500 patients and athletes, the outcome after the 3 different treatments. As we can see, bicep tenodesis has an older age of 42, but also has a better outcome of 78% return to sports rate. On the contrary, slab repair or repair plus cuff debridement will have 63 to 66% of return to sports rate. Of course, there are some limitations to this systematic review. The control of age is probably a problem. We can see that older people benefit from tenodesis. And those articles did not clearly define the level of activity or what types of sports they played. And again, overhead and non-overhead probably have a different result. This is a biomechanical study using EMG to look at the neuromuscular control on biceps, long head and short head, deltoid, infraspinatus, and latissimus dorsi. And among the 3 groups, control is the uninjured one, and bicep tenodesis and slab repair, the 3 groups, has no significant difference on neuromuscular control. And on the motion analysis, actually the 3 groups didn't have a significant difference, except the slab repair has a slight altered thoracic rotation. We performed 16 slab repair on elite athletes during the year 2014 and 2016, and with a minimum 2 years follow-up. And we can see that 81% of them are baseball players, and 63% are at the level of professional. And the return to the pre-injury level rate is about 12 patients out of 16 can return to pre-injury level, which is about 75%. As to cuff tear, the associated cuff tear seems did not make any significant difference between return to the same level or not. But of course, this is a small sample size. We probably need to collect more data to see the differences. This is 11 months after slab repair and supraspinatus repair. And he was able to return to full competition at, again, pitched at 150 kilometers per hour afterwards. And this is more severe colliding injury, contact injury. This infielder actually had a slab extending to Bankar. So he had a slab repair plus the Bankar repair afterwards. And 10 months after the surgery, he was able to return to play and perform well on defense and also on offense. This is another picture, also had a slab extending to Bankar. And 13 months after the surgery, he was able to start interval throwing program. So being a surgeon, we've been doing surgery in the hospital, but in the future, can we define or find the injury mechanism better, and even to develop a protective program to prevent injury in the future. And we know that GERD is a possible risk factor for SLAP or shoulder injuries. So we did motion analysis to look at the effect of GERD on pitching arm. So this was brought out on an outdoor ball pen and with a high-speed camera. So we found out that pitchers with GERD has a higher shoulder superior force and higher shoulder internal rotation torque. That can also jeopardize the soft tissues around the shoulder, such as biceps and the cuff. It also has increased elbow joint medial force and varus torque on the group with GERD. Another risk factor is when you are fatigued and you still pitch, it has a 36-fold of risk. So this is another study that we did to compare out of 100 fastball pitching. We compared the first 10 pitches and the last 10 pitches. And the first video here is the first 10 pitches, and the one on the right is the last 10 pitches. It was taken at 300 hertz per second. So as the motion or the kinematics, we do see this. But first, there's a decrease in ball velocity in the last 10 pitches. And also, there's a decrease on the shoulder external rotation angle. That could be from the tightness of the shoulder. And also, there's an increase of leading knee flexion angle. And this could also be the result of fatigue from the lower extremity. And also, there's an increase of trunk forward tilt and an increase of shoulder horizontal adduction. So we term these signs of fatigue, and this data can be shared to the coaches and to the catchers to detect early fatigue phenomenon from the pitcher. Even though the ball velocity decreased, we do see that there's an increase on the shoulder force, on the shoulder horizontal adductor moment. This is also happening on the elbow. There's an increase on the anterior posterior force and also on the valgus torque. That also tells us that when you pitch, if you are fatigued and you continue to pitch, then you are putting risk on your shoulder and the elbow. And as for the muscle power, it takes at least 3 days of rest before the muscle power can recover. So another thing we want to look at is, does early cocking phase mechanics affect pitching arm? So this is a study that a retrospective study that tells us that early trunk rotation mechanics can increase the risk of shoulder and elbow surgery. So also we did this on the motion analysis to look at, is early trunk rotation really hazardous to shoulder biomechanics in baseball throwing? So with our new way of evaluating a pelvic and trunk rotation, we can define early trunk rotation group and also the non-early trunk rotation group. So there are 36 in the non-ETR and 21 pitchers in the ETR. The demographic data are compatible, but the velocity is higher on the non-ETR. What about on the shoulder joint loading? We do see that the group with early trunk rotation, there are higher inferior force, proximal force on the pitching arm. And also, there are higher horizontal adduction and vertical adduction moment on the pitching shoulder. So as in conclusion, even though we are surgeons that treat patients, but if it's possible, if we can prevent injury and give them a better career, that's probably our goal. So we should respond to the signs of fatigue and then honor the proper pitching count and the pitching type. And proper throwing mechanics are necessary to prevent injury. So hopefully we can design and help the coaches to design a better training program to reduce the risk of injury in the future. And there are some of the pictures from Taiwan showing that we have a beautiful scenery and also a lot of good dairy and good food. So hope that there are chances for you guys to come to Taiwan and visit us. Thank you.
Thank you, Professor Zhou, for the excellent result, and especially for the slab repair. We know that because there's many. The Professor Zhou's. Let me explain first, because Professor Zhou's patient, you can see they are playing professional baseball, and they are pitchers. They are like pitcher for professional teams, and they are pitchers for national teams. So they are really high elite players, and we can see that like 75% successful rate is very high in the slab repair, which reminds me that when I was with Alex, he told me that in his life he have only done 2 slab repair, and these 2 are disasters. So is there any discordant? Is there any difference between the the sports type between the Europe or Taiwan, or what's your thought about slab? Is it weren't fixed? And do you have any age limit for the slab repair, or over which kind of age you do a bicep tenodesis instead? Thank you.
Is it a question for me or for Dr. Lehman?
For Alex, it's a congratulation for you, but it's a question for the European. Yeah.
Joe, you have a very good memory, because effectively I did 2 slab repair in my life that I still regret. When I was with Steve Burkhardt, we did a comparative study, slab repair versus tenodesis, and it was about patients that were older than 35 years old. And there was a clear advantage for tenodesis. The patient had less pain, and they were redoing their activities quicker than if we were repairing the slab. So I based my practice on this study, and interestingly, a lot of people were saying, okay, your study is great, but we are treating athletes, and the athletes are usually less than 35 years old. And in December 2021, in the AGSM, Barnes on a military cohort found exactly the same result that we find with patients that were older than 35. With patients that are younger than 35, he found exactly the same result. So I think that we can say today that at least tenodesis is one option. And I am aware of other study that has been published since. There are study of Hurley that demonstrated that slab repair provides good result even at 5 years. Ridley also find that slab and tenodesis is comparable. So I think that today we know that both are possible, and this is rather a question of philosophy than, or maybe of technique than, and I'm not sure that there is real any more debate about this. You can do whatever you want. If you do it well, you will obtain a good result.
Yeah, and we have some question about from the audience. Is Dr. Guo is from Jiayi Chang'an Memorial Hospital, and he asks about the same question. Prefer decide between the tenodesis or slab repair in elite baseball players, and how to minimize the limitation in external rotation, range of motion after surgery. And I have the same question for Professor Zhou. Do you determine from the slab repair or bicep tenodesis according to their position? I mean, if they are pitchers or if they are infielders or outfielders, does it mean anything to you? other than the age?
Okay, thank you. I think from the paper we reviewed that we do see that bicep tendinosis actually has very good result also. For my experience, I usually just do slab repair if it's a type 2 slab, but I will preserve bicep tendinosis on patients with type 4 slab lesions. And I do not make any difference whether it's a pitcher or it's a other positional player. But I think we are very lucky because these elite athletes, they do have a strong rehab team. The athletic trainers, actually, they are doing a very good job because this is just a standard technique. I'm not doing anything fancy, just put it back in the same place. But I think that the team afterwards really did a good job. So as to the range of motion, that all will be counting on them. And also for these athletes, a lot of them are combined with shoulder internal rotation deficit. So a lot of the stretching exercise after the surgery are very helpful to help them regain their normal range of motion.
Okay, cool. And another question, the last question. I think the result of combining the slab repair and the pasta repair are very good and very promising in Professor Zhou's series, but which was in the States, they provide only 65% return to play. So do you think is there any difference between anterior pasta or the posterior pasta? Because for throwers, most of them have posterior pasta, which might be which might be an overuse injury, and which might be a adaptive injury, not the real injury.
Okay, yeah, that's also a good question. I think the case number are too small to tell the differences, but I do believe that with associated rotator cuff tear, the chance of return to play is not as high. So for there's only one of those 16 cases that do require a rotator cuff repair. Actually, the others we only did a debridement because the partial thickness tear was not that big. Yeah, I think it was less than 25%. So we only did a debridement.
Okay, cool. Yeah, thank you, Professor Zhou. Because of time, and we got still Professor Xu and Yang. We got two very complicated cases and need your expertise. You need your expert opinion. Okay, thank you, Professor Zhou. And Dr. Yang, can you present the two difficult cases to the audience?
Yes, sure. So can you see my slide now? Yeah, sorry. Can you see my slide?
Yes.
Can you hear my voice? Hey, hello everyone. I'm Dr. Yang from Chang'an Memorial Hospital, and this two cases were supervised by our hospitals, the whole team of our hospital, and I'm just jumping to the first case. The first case is a 56-year-old female, and she was sent to our emergency room due to the falling accident for 1 day. And this is the initial X-ray at the emergency room. We can see the fracture line is through the distal to the surgical neck, and there's a linear fracture near the greater tuberosity. Okay, and this is the this is the CT scan of the fracture, and this is the 3D CT. So, at first, the trauma surgeon decided to do a nail fixation using Smith navicular humerus nail, and this is the intraoperative image. Okay, so sadly, the next day, the X-ray showed the fracture fixation was totally loosened, and I think the GT is blew out during the operation. So back to, I think, the treatment options. The treatment option, do you need observation, revision with plating, revision with hemiarthroplasty or straight to the reverse total arthroplasty. Okay. So at that time, the trauma surgeon decided to revision with the original nail and using cement for augmentation. Okay, so that's the post-operative X-ray. And later on, 1 month after the second time operation, the fracture loosened again, and the humeral head collapsed to the posterior. And because the patient is very skinny, so the humeral nail and the cement just tenting at the skin. So the patient came to my clinic where I do the physical examination, both passive and active range of motion is severely limited. But there's no shoulder region numbness over the axillary nerve region. And maybe I cannot be sure whether active flexion was limited by the calf lesion or the cement or the loosened fracture. So further examination, I arranged both CT scan and MRI. And the CT scan just showed the humeral head collapse to the posterior and humeral nail tenting at the skin. This is other CT scan image. And the MRI showed the cuff is still intact at the greater tuberosity and lesser tuberosity, but some retraction is the great GT and LT were already retracted a little bit. So there's different treatment options now. Conservative treatment. Should I do a revision ORI again? Should I do the hemiarthroplasty or should I do the reverse arthroplasty? Okay, so my choice at that time is I plan to do the reverse total shoulder arthroplasty because I'm afraid I could not repair the GT and LT to have a good soft tissue envelope. But some tragedy happened again because the patient is very skinny and the bone quality is very, very poor. So while I did a central screw insertion, I didn't feel anything. And also the forward-locking screw didn't have any feeling about the bone itself. So after I did the glenosphere fixation and doing the cemented stem, well, I do the trial reduction, the glenosphere just fall out of the glenoid. And I want to do the bone grafting for the glenosphere side, but it also failed. So I just changed to the right shoulder hemiarthroplasty and did some femoral head allografting for the glenoid side. And I think maybe spending 1 to 2 hours to release the GT and LT. And luckily, I can complete repair of the tuberosity. And this is the immediate post-operative CT scan. Okay, so 2 weeks after the operation, the deltoid tone was very poor, but 8 weeks after, the deltoid tone become better. Okay, so this is the first case. Professor Xu?
Yes, we have a lot of questions to ask the expert. Like in the slide, how to decide to do reverse preoperative, how to decide the risk of the operation. Can we estimate the risk of glenoid loosening I will ask the expert here to express your opinion. Thank you.
Okay. Yeah. As I said, it's a very nice case. So I think that the preoperative, and you asked the right question on your slides. You need to have a good plan, and a good plan. If you do a good plan, you need to exclude some greater tuberosity fracture before the surgery. If you have any doubt, or if there is a greater tuberosity fracture, you know that percutaneous kneeling is going to be a very tough surgery. And with the initial displacement, you can imagine that there is no way to introduce the nail at the right position if you don't put the human head back at its place. If you want to avoid, you need to correct the valgus. And what happened in this case, the nail is too lateral, and actually there was not a good bite into the proximal part, and this is why you observe a secondary varus collapse. So you need to have a good plan, and you need to choose the right implant. If you have a look to your intraoperative fluoroscopy, you will see that this type of nail, yes, perfect, thank you. It's not really an anatomic procedure because there is clamp, so you go through the skin, through muscle, you don't control anything. You cannot see the shape of the long hand of the biceps, and if you have a look to the preoperative X-ray, you know that the biceps should not be in such a good shape, so maybe you need to do tenodesis of the biceps. So for me, if I have this type of fracture in a rather young patient with a good cuff, a greater tuberosity fracture, I will for sure do a standard deltopectoral approach and fix it with a plate. This would be my first choice. And the problem is, with this type of fracture, you have one chance. There was no two chance. It's one chance, so it's either you do it right the first way, or it's becoming a disaster, and this is clearly what happened later on.
Yeah, after the two successful series, we got a real problem now. Okay. So, can you hear me? Can you hear me?
Yeah, sure.
Yeah, because I was just because of the internet reception is not good. Just take a nap. So, Alex, what's your opinion at this moment? I mean, yeah, since the disaster is there.
I think that at this moment, it's already a disaster, but you can still win the game. And I would, for this type of fracture, so revive the patient, do quite an extensive deltopectoral approach, remove the nail, and then I will do a combined approach, meaning that I will use an intramedullary autograft with a fibula, and then reconstruct, so reduce the human head with a bill bucket technique, reconstruct the greater tuberosity, and plate it. This would be my choice at this point. I think that at this point the cuff is still okay. I won't use, of course, a nail again. I will revise with a plate, and at this stage there is no place for arthroplasty in my hands.
Okay. So yeah, clearly the first surgeon revised with a nail, not a plate. So I think with the same reduction. So okay, so yeah, it's not an easy day every day.
No.
Okay, like this. And okay. So what now? You have failed 2 surgeries already, and the head it seems not good anymore. So
Correct.
yeah.
So at this stage, of course, I will make sure that the nerves are okay. So I think that EMG makes sense, and I will clearly plan a reverse shoulder arthroplasty. We know that postoperative, so fracture sequelae is best treated with reverse. So I will go for a long reverse. You need to at least bypass the two distal screws. So long stem and a quite standard reverse shoulder arthroplasty, trying to reconstruct some kind of posterior cuff if there is still something.
Yeah.
I would take, of course, biopsy, culture, and keep my patient on the antibiotics until I have the definitive results of the culture.
Okay. Thank you. And yeah, for this case, because they're in our national insurance guidance, only patient after 65 years old can be covered by the insurance for reverse. But luckily, this patient got insurance in reimbursement because of the situation is too difficult. And Dr. Yang have done the surgery, have done the reverse for him. And during the surgery, Dr. Yang, are you there?
Yeah.
I'm not there, so yeah.
I don't want to think of this case.
Okay.
Yes.
So I think because he have been the lady has been traumatized too many times, so there might be a like osteoporosis around the glenoid. Yeah, normally the glenoid is very strong, and but for this kind of case, do we need do a bone marrow bone density exam before the surgery? And if there's very osteoporotic, did it change your mind to like do some injection and then put the reverse afterwards, or it doesn't matter? Yeah, what's your opinion, Alex?
I think honestly you did the right choice. I wouldn't do any more of additional exams. I will go for a reverse. Glenoid, intraoperative glenoid loosening is rare. This is usually due to intraoperative fractures, and this is something that clearly can happen, and I had already a few of them. It's clearly not easy to manage. In the study that we published in 2019, what we show is that if intraoperatively something is going wrong, like if you have a glenoid loosening, you should stop. And this is what you did, and I think it was the right choice. Another choice would have been maybe just to try to fix the base plate without any stem, let the glenoid or the scapula healed, and then go back 3 to 6 months later for a second stage revision with glenosphere impaction and stem revision. But your choice was, I mean, absolutely correct, and this is clearly an option that I will have to think about.
Yeah, thank you, Alex. And we are planning, we are planning to visit you with the surgeons after the pandemic is controlled, and we'll see because you have done a tremendous job in reverse, and I always told them repeatedly how fast you are and how successful the reverse you are. So yeah, we'll see, and we'll visit your surgery. Okay. And because of the time, we should move to the second case. Dr. Yang, please. And please.
Okay, I just moved to the second case. The second case is a 70 years old female, and she also hurt her shoulder in a falling episode and had a fracture dislocation. And here's the CT scan of the right shoulder. You can see clearly a very comminuted fracture, proximal humerus fracture with involvement of GT and LT. So what's the treatment options now? And okay, I just jumped to the trauma surgeon's choice. The trauma surgeon did open reduction and internal fixation with Synthesis Phyllis locking plate. And here's the initial postoperative X-ray. 3 months after the operation, the shoulder was still inferior sublux. And 4 months after the operation, it is still sublux. So the patient complained about the shoulder subluxation and has visited the emergency room due to the same reason multiple times. So what's the next step? Okay, at first the trauma surgeon arranged a CD3D. And here's some slides of the CD3D. So what's next step? Okay. The trauma surgeon decided to revise the fracture fixation, I think primarily at the greater tuberosity. However, the 2 weeks after the operation, the deltoid tone was still poor. And the lady just lost follow-up at our hospital. And after she came back 1 year after the first operation, she already received a C-spine ACDF done at another hospital because the doctor told her she had a C-spine lesion and causing his right shoulder problem. And okay, so we can see at the clinic, her shoulder function was really, really poor. Okay. So what's the next step? Should we observation and rehab until the deltoid tone recover? But it's already 1 year after the second time operation. Should we revise the fracture fixation? Should we do a hemiarthroplasty or reverse total arthroplasty? Or I still have some more information because this cuff tissue seems adequate. Glenoid side is not good because of screw penetration. You can see humeral head already collapsed, maybe due to the vascular necrosis. So that's the final X-ray 1.5 years after the first time operation, and the patient suffered from a vascular necrosis and inferior subluxation. And we also arrange a NCV and EMG, which is compatible with brachial plexopathy, involving upper and middle trunks. But the patient's elbow and wrist function seems adequate at in the physical examination. So that's proximal humerus fracture dislocation with 2 times open reduction and repeated subluxation with humeral head collapse, and maybe brachial plexus or axillary nerve injury was also presented. So that's the end of this case because we didn't did another surgery yet. We can present it here. Okay, back to Dr. Chu.
Yeah, and you know, Dr. Lederman had a perfect paper about this kind of. You still can do a reverse shoulder in people with axillary nerve injury on
Yes.
if the anterior deltoid is intact, right? And I think the interesting part is for this patient, she kept have the problem with the shoulder subluxation, but at the final follow-up, you see there's some proximal migration of her subluxed shoulder. So yeah, of course, for the salvage procedure for malunion, reverse is a good choice, but considering the nerve lesion, I think it's a very difficult for all shoulder surgeons. So what's your Professor Guoyao Xu, and what's your opinion about the patient? And do you have any thought?
Yes, I would ask the expert here. First, some patients have inferior subluxation after the fracture, but for this unique patient, we see the inferior subluxation is very, very severe, not like the usual inferior subluxation. And at this time, we think this is combined nerve injury. So before the second revision surgery, what would you prefer? To do a reverse or revise the fracture? That's my question. And I think the recovery of the inferior subluxation it's very long. It takes 1.5 years. Usually, the normal sequence is only 6 months. So I think this is a very unique case. So do we need to wait for the nerve recover, or we just go ahead at the initial? Alex, can you answer my questions? Thank you.
Yes, thank you for this very interesting question. So if we go back at the beginning on the first CT scan, the first thing I would say is that with such an image, I will go straight for the reverse. Usually, reverse for trauma is done in my hands through a Schwan's deltoid approach, but this is not a good approach with such humeral head displacement that is really in the plexus. So for this type of lesion, I will do a deltopectoral approach. And if I have any difficulty to find or to retrieve the humeral head, I will add an osteotomy of the coracoid process to have a vector access and make sure that I do not create neurological lesions. I don't see well the anterior glenoid, but you need to know that from time to time, with such fracture, is associated. These bad fractures are associated to anterior glenoid rim fractures, and if this is the case, there is zero chance to stabilize the shoulder with a simple proximal humeral osteosynthesis. So you need to go straight to the reverse. Then, I think that the postoperative X-ray is okay. Nothing to say. Then, if you go back at the 4 months follow-up or 3 months follow-up, perfect. There is an instability, and we know that instability is not so great for nerve healing. So this kind of anterior or inferior translation is associated to axillary nerve lesion. And if you want to promote nerve healing, you need to stabilize the shoulder. So however you want, but this shoulder has to go back at its place if you want to obtain a nerve healing. So at this point, I will go again straight for the reverse with a lot of lateralization in order to not to stretch too much the nerve to avoid a double crush syndrome. So I will remove the plate, do an important lateralization, big head, and I wouldn't move my patient during at least 6 weeks to promote nerve healing. So this would be my choice at this point.
Thank you. Thank you very much. Yeah. So I think if we found this kind of severe injury, you have a high risk of failure of open reduction and a high risk of become a late sequel like avascular necrosis. So maybe we should do a reverse at the first. Thank you, Alex.
Yeah. Okay. So two very difficult cases. Yeah, I think the planned time will be like 1 hour, and we are a little bit more than the scheduled. I think the audience or the panel, do we have more question about these cases?
Joe, there is one question from Eddie Lu, who is asking, how do you, in which position do you proceed when you do a labral repair? Is it bead chair or lateral position?
Mm-hmm.
I usually do it on the lateral position.
Okay.
Dr. Joe,
Yes.
what is your attitude?
The lateral position for the labrum, whatever superior or inferior or posterior.
Yeah, for me, I do all bead chair because because I'm trained to do so. So if the instability is too severe, I just go ahead to Latarjet. So for me, if there's no bone defect and no granule bone defect, I do bead chair, try to labor as possible. But if there's any general defect, like more than critical defect, like more than 10%, I may go directly to Latarjet because I've trained with Alex, and this is the best French surgery I've ever seen. So you have to follow Alex's step, and he has just published his technique on arthroscopy technique, and we can all view it and try to do the best for the patient in Taiwan. Yeah,
Joe,
that's my opinion.
Joe, this is the best French surgery of the world. Don't forget
Okay.
it. There is one more question. In first case, should we check nerve before surgery? This is a very good question because, first of all, so this patient had a fracture dislocation. Even if Geneva has a lot of neurologists, it takes me usually 3 to 6 weeks to have the first appointment. Knowing that there is some axillary nerve involvement in 60% of the cases, I'm not going to wait for an EMG and I will go straight for the reverse because, again, reduction, maybe postoperative immobilization, is the best way to promote nerve healing. So I will not wait for another exam and will go straight for the surgery.
Mm-hmm. Okay.
Friends from Taiwan, I think it was a great session. I would like to thank you all. Thank you, Joe, for organizing this great meeting. So thanks for your participation. The next Learn from the Master in Shoulder session will take place on the 24th of May at 20 CET. And this will be Dr. William Leving that will present shoulder instability and bone loss in 2022, current approach. In the meantime, we encourage you to visit the app bmed.com, update your profile, share your patient cases, and explore the exciting new content. You have to know that we organize in 2 weeks a huge meeting in Val d'Isère, the Val d'Isère Shoulder course. You're, of course, all welcome. It's snowing, so it's going to be very nice. If you can't come, you can register on BMed and already upload cases on the website that you would like us to discuss about during the Congress. Thank you, all of you, and I hope, as it has been said, that I really hope that I will see you soon. Thank you, guys.
Thank you, Alex.
Thank you very much.
Thank
you, Alex.
Thank you.
Thank
See
you.
you.
Okay, see
See you.
you. Okay.